Oh, wonderful. Thank you so much. And thank you once again for having invited me to be here in my second university, Hanoi Medical University. Is definitely part of my heart. And the possibility to meet once again the scientific community of this university for me is tremendously important. I hope that you may enjoy this lecture about duboxetine and premature ejaculation. And I will show you some data which are coming from several groups, but also from my scientific group of endocrinology and medical sexology in the University of Rome, where I'm coming from. Those are my so-called disclosures. And let's go to the agenda that we will discuss together now. Later we will have a possibility to make questions, so please feel free to ask if something is unclear. First, we will deal with time, control, and interpersonal difficulties which are present into the most frequent sexual male complaint. That's premature ejaculation is. So if you are interested in sexual health, if you are interested in andrology, definitely you must take consideration of premature ejaculation. Then we will go to the gold therapeutic standard of premature ejaculation, which is duboxetine. We will identify the population of patients who may more likely benefit from duboxetine use. Duboxetine, as any drug, is having some few side effects, and we will understand how to minimize the side effects of duboxetine. And finally, we will go to the real life example of duboxetine around the world. So let's start with the understanding, first point, how to understand the concept of time, the concept of control, the concept of interpersonal stress, difficulties, and effects into the couples, and to explore the multifaceted nature of the success, of the therapeutical success, in order to recognize what is encompassing various dimensions to reach the personal fulfillment. This book was the first book published into the field of premature ejaculation. I had the honor to be the editor together with a doctor from Australia, Chris McMahon, and a psychiatrist from Netherlands, Marcel Valdiger. And one of the chapters were dealing about the psychological factors which are related to premature ejaculation, which are always to be considered important. But to be very clear on what the premature ejaculation is, you have just to follow this graph. This is the normal patient. This is the normality. This is the beginning of the excitation. This is the phase of plateau. Then there is the orgasm, and finally the resolution. So this is the normal situation. But this is premature ejaculation. In premature ejaculation, as you can see, the excitation curves is going very, very fast. And the plateau phase, where the intercourse is occurring, is very, very short. The pleasure is even lower, and then there is the resolution phase, the refractory period. Then, of course, there is another possibility, which is the delayed ejaculation, where the plateau is so long. And finally, there is also the possibility of not having ejaculation, the so-called anejaculation, very important from this perspective. A major problem in the past was the definition of premature ejaculation. It has been a huge discussion how to define premature ejaculation. For example, for FDA, for the American Agency of Drugs, premature ejaculation is considered not a disease, not a symptom, almost nothing. And in fact, they do not have a drug for premature ejaculation. This is a lack of intelligence of the American medicine agency, but we met in Bangalore many years together under the umbrella of the International Society of Sexual Medicine in order to produce the first evidence-based definition of premature ejaculation, which is based on three major factors. One is timing, could be from 1 minute to 3 minutes. One is the inability to control, the issue of control, and finally the distress produced into the couple. So we do have three different aspects. One is time, one is control, and the third one is the distress. Then we have several different possibilities. One is the so-called lifelong premature ejaculation, which is starting from the beginning of sexual life. Then we have the acquired premature ejaculation. But the problem is that definitely premature ejaculation is the most, as I said, the most common male sexual complaint, but it's not the most common reason for coming into the office of the andrologist. So the consequence of it is that premature ejaculation is still underdiagnosed as well undertreated. Why? The reasons are several, because we need strategies in order to change this figure. The most frequent male sexual complaint, not the most frequent reason to go to the doctor, to go to the andrologist. Scientific production is the way to antagonize this figure. In other words, this is the graph showing how it is increasing the scientific production in premature ejaculation according to what? To the scientific production and to the definition of premature ejaculation I showed you before, then the guidelines, then the definition of premature ejaculation into the reference book of the psychiatrist, the guidelines from the International Society of Sexual Medicine, and finally the presence of premature ejaculation within the taxonomic classification of the World Organization of Health. So the booster of premature ejaculation science have been two boosters. One is the discovery of the efficacious drug as dapagliflozin, the drug we are going to talk together, and then the debate about the premature ejaculation definition. Those are unpublished data showing how much is the distribution of the articles, scientific articles, published into the premature ejaculation globally. As you can see, the country I'm coming from, Italy, is one of the best producers. And here is this graph is showing the connections between the various countries and the results of the international collaborations involved in the premature ejaculation research. So the thickness of the line represents the frequency of the collaboration. As you can see, the peak one, which is Italy, is having, together with the United States, a very great network, web of collaborations around the world. Then about the scientists. The sides of the circle is highlighting the scientists who did the majority of production in the premature ejaculation. Unfortunately, Marcel Waldinger passed away a few years ago, and now one American, David Rowland, one doctor from Hefei University in China, and myself are the major producer of articles on premature ejaculation. So this should stimulate further collaboration in the field of premature ejaculation. Diagnosis. In order to make a diagnosis, let's have a look on what? On the American Urological Association, European Urological Association of Urology in order to make the definition. The first is what I said before. Premature ejaculation is matter of timing as measured by ejaculatory latency time, is matter of perceived control, is matter of distress and interpersonal difficulties. This three-dimensional definition is coming from my article on premature ejaculation, Old Story and New Insights. Then premature ejaculation is diagnosed with the so-called patient-reported outcomes. The patient-reported outcomes, or PROs, are very important in order to make this kind of definition, and this, again, is coming from this article published regarding the psychometry of male and female sexual dysfunction. Premature ejaculation is also overlapping sometimes with erectile dysfunction. This is a major point. Please do not consider erectile dysfunction in one side, premature ejaculation in the other side, because very frequently they are together. About 50% of the patients, they do have premature ejaculation comorbid with erectile dysfunction. And this was the first article showing the correlation between ejaculatory and erectile dysfunction. Finally, another very important point. Unfortunately, many doctors in Europe, as well in the United States, are not visiting the patient with premature ejaculation, are not putting the hands on the body of the patient with premature ejaculation. This is indeed, my friends, a major mistake. And we definitely define it in the standard operating procedures into the disorders of orgasm and ejaculation, that there is a need to have a physical examination of those patients. Let's go to the core business of our talk, which is the therapeutical options. We have several non-pharmacological treatments as well pharmacological treatments. The non-pharmacological or psychological treatments or behavioral treatments or psychosexological treatments are based on psychoanalysis and as well as psychotherapy sometimes. We do not have so many data regarding the real output of those approaches. Definitely the counseling is tremendously important. If you are not discussing with the patient, the output, the therapeutic output will be very low. There are also some approaches without so much science related to the meditation, hypnotherapy, but also the precoital masturbation can be considered one kind of behavioral therapy. Some people are using a medicated condom with anesthetic drugs, and also there are the so-called Kegel exercises, which are making most strong the pelvic muscles in order to improve the control over ejaculation. Extending the foreplay, trying to make a distraction, cognitive distraction, trying to find alternative position, and also some palliative intervention to premature ejaculation. But we do have several drugs which can be used for premature ejaculation. All those drugs are off-label. The unique one which is on-label is daboxetine, and I will show you why this drug is so important for the treatment of premature ejaculation. Then we can try to use anesthetic creams, we can try to use opioids like tramadol. We may use tricyclic antidepressants as well, SSRIs, selective inhibitor of the reuptake of serotonin, in order to use the side effect of those antidepressants, which are well known able to decrease the sexual desire, to decrease the sexual arousal, and finally to decrease the ability to ejaculate. But also, as I told you regarding the comorbidity with erectile dysfunction, There is also the possibility to use a PD5 inhibitors, and there is also some room for traditional medicines. There are several remedies as well, acupuncture, which may have some little role into the treatment of premature ejaculation too. Are there something in the pipeline? Are there novelties in the pharmacology of premature ejaculation? Yes, they are, but unfortunately, they are all to be considered as scientific failures. No one is going up, and the unique drug specific for premature ejaculation we do have is still dapoxetin. So let's go to the second point. The second point is to understand the mechanism of action of dapoxetin and how dapoxetin is impacting into the ejaculatory control, is able to increase this control on the basis of the clinical studies and on the basis of the research findings demonstrating the efficacy and safety of dapoxetin in the treatment of premature ejaculation. Basically, we have two different parts of the balance of human excitation. Some are definitely stimulatory, are increasing the excitation, are increasing the ability to ejaculate, and there are three, one neurotransmitter, which is dapoxetin, and two hormones. One is the oxytocin, the other one is testosterone. The vice versa of dapoxetin, we can say, is the inhibitory neurotransmitter serotonin. Serotonin is a very complex substance which is having a lot of different behavioral action and results, but serotonin in this case is decreasing the level of excitation, decreasing the level of desire, and decreasing the ability to ejaculate. Also, we have prolactin, which is an hormone which is reflecting the decrease of dopamine. When prolactin is increasing, it means that the dopamine is centrally decreased, as well the natural opioids, like endorphin, which being a stress hormone is also having the ability to decrease the sexual drive and to decrease the ability to ejaculate too. This is the complex picture showing the neural control of ejaculation. As you can see, there are several nerves controlling into a positive way the mechanism of ejaculation, but also in negative way. What is very important to understand is the fact that there are higher brain centers which are inhibiting the periphery in order to decrease the reflex arc producing the ejaculation. So there is a peripheral stimulation which is triggering the mechanism of ejaculation, but there is also a central control which is basically based on the serotonin presence. Serotonin, again, very, very important. You know that serotonin is working into the synaptic cleft, into the space between the first nerve and the second nerve. There are receptors, several kinds of receptors for serotonin, and this is the production of serotonin. You can have two different patterns. One is the acute block of the serotonin reuptake, so the acute administration of an SSRIs, and the other one is the chronic one with a different output. The first one is increasing the control over ejaculation, is increasing the time parameter. ILT means intravaginal ejaculatory latency time. It means the time from the beginning of the intercourse, of the penetration, until the end of the penetration, until the ejaculation. This kind of treatment, the acute one, is not modifying the mood because it's not crossing the blood-brain barrier. There is not way to modify the mood. It means no side effects, no risky side effects, no other kind of side effects, and no post-SSRI sexual syndrome, which is a syndrome I will deal with later. While on the contrary, if you are doing a chronic SSRIs intakes, you have definitely an increase of control and an increase in IRT, a decrease in the stress, but you have to face a mood modification. How many of you are psychiatrists? I think not so many. And this could be very risky because you are impacting into the mood, you are producing a lot of risky side effects and sexual side effects, and possibly producing the post-SSRIs, sexual disease, sexual syndrome, which is very, very important, very frequent. So in this article, I produced this cartoon, which is showing that basically in premature ejaculation for psychological, for physical, and maybe for genetic reasons, you have a low central activity of serotonin, which is producing a reduced feeling of control, and finally premature ejaculation. And the best way to understand this cartoon is that in the patients with premature ejaculation, there is a high need of serotonin, which is producing low feeling of control, and finally, premature ejaculation. So premature ejaculation, as I said, is a three-dimensional condition with a three dimension. One is the control, one is stress, and Y is time. And if you wanted to make an Olympic podium of these three aspects, we have to admit that the bronze medal is the time. Very important from a clinical perspective. Never listen the patient just for time, but ask for the other things like the silver medal, which is the distress produced into the couple. And finally, please consider it as a gold medal, the control, which is very, very important in order to understand what premature ejaculation is. Patient with premature ejaculation is a patient who is losing the control over the mechanism of ejaculation. It's not just a matter of time. It's something much more complex, much more important, as demonstrated in this seminal work from a psychologist from Valparaiso University, Professor Roland, who demonstrated how pivotal is understanding how premature ejaculation is based basically on the perceived control over ejaculation and much less on the satisfaction, on the timing, as well on the distress, which are important, but not so important as the feeling of the loss of control. I said three dimensions, but we have to add a fourth dimension, which is a new one. So how to address this fourth dimension? In order to do it, I went to my neurologist friends who are dealing with the pain, and I realized, as you know, as a doctor, that the unique way to assess the pain is to use a visual analog scale. A visual analog scale that we can call pinometer is a very, very simple scale that you are always using when dealing with the patient pain, where 0 is no pain, 10 is the worst possible pain. And that this visual analog scale is universally used as the unique way to address pain. What I did, I make vice versa the scale, I reverse the scale, and I produced what I call the male orgasmometer, published it in Andrology, and showing that you can have 0, which means no pleasure, and 10, the best orgasm the patient can believe. The orgasmometer is having a wonderful psychometric characteristic, wonderful psychometric aspects with a very high sensitivity, a very high specificity, as this Rocco curve is demonstrating. And what we found is that in premature ejaculation, there is a reduction of pleasure. There is a reduction of the amount of the intensity of orgasm. And this is very important in the communication with the patients, because many patients, many couples, many wives, they believe that a patient with premature ejaculation is a selfish people. They believe that they are considering only their own pleasure and not the pleasure of the wife, which is completely wrong. We demonstrated that those poor people are experiencing a very low amount of pleasure, as demonstrated by the orgasm of interest. So this cartoon, which is a new one I prepared just for this meeting, is a cartoon showing the way to increase the fourth dimension, where you have a premature ejaculation here, but also the dimension of control, the dimension of distress, the dimension of time, and finally, also this new parameter, which is not usual to be considered in the anthropological setting, which is orgasm, pleasure. So, how to call the paroxetine? How to call the paroxetine with our patients? How to present the paroxetine to our patients? One way is that one, the controller of control. And in fact, it is, according to the gold medal I told you, the best way to understand the premature ejaculation as well the treatment. The paroxetine is the gold standard, is the first choice oral treatment for both lifelong and for acquired premature ejaculation, where you have been unable to find a specific treatment, like for example for prostatitis, like for example for hyperthyroidism, in order to cure acquired premature ejaculation. Because the paroxetine is increasing the concentration, the local concentration into the synaptic cleft of serotonin, which is producing the increase of control and solving the problem of premature ejaculation. This apparently complex pharmacokinetic profile is very simple. It is demonstrating why the paroxetine is not an antidepressant, is not having any typical side effect of the antidepressant. It is because the Tmax, the timing the drug is reaching the maximal concentration in the blood, is very fast, is about 30, 45, 60 minutes, so it's very fast. But what is very interesting is the fact that the half-life is very short. Short means that there is no risk of accumulation. And the accumulation is the major reason why the SSRIs are working into the mood. Without the accumulation, the SSRIs are not modifying the mood. And the paroxetine, thanks to this particular pharmacokinetic profile, is very short in order to do it. And this is even more clear when you are comparing with other SSRIs like paroxetine, sertraline, and fluoxetine, which is very popular and unfortunately used in premature ejaculation, which is, in my mind, a big mistake. Because, as you can see, this is the profile of the paroxetine, very short, means no accumulation. While the other SSRIs, they do have a very long half-life. It could be an half-life of days. It means that the side effects could be very important. So here, few hours, here, many days. So the European Association of Urology, again, is admitting that for the premature ejaculation management, it is important to use daboxetine, as written here, as the first option for premature ejaculation itself. Another question is about how the European Association of Urology is presenting daboxetine, which is present in Europe at 2 doses, 30 and 60, but here in Vietnam you have only 30 milligrams, which is not a big problem because 30 milligrams is the most frequently used dose in Europe too. It is taken from 1 hour to 2 hours before the intercourse, and it is effective on time. It is decreasing the ejaculatory control, is decreasing the distress in the couple, and finally decreasing the satisfaction in the couple. And it is interesting that we do have also in Italy, in Europe, the cream, the gel with prelocaine, lidocaine, with anesthetics, but this is approved only in acquired premature ejaculation, while the dapagliflozin is approved in both acquired and lifelong premature ejaculation, so it should be considered the first choice. This meta-analysis is very interesting because it is based on 11 randomized controlled clinical trials with a huge number of cases, so the results which are coming here are very, very interesting and important. The first one is the forest plot of the perceived control over ejaculation, and the dapagliflozin is much more effective than placebo. Then we will go to the patient-reported global impression of change. Again, once again, dapagliflozin is much more in the meta-analysis, much more effective with respect to the placebo, significantly more effective. What about the timing as measured by the ILT, intravaginal ejaculatory latency time? Once again, dapagliflozin is much more effective and is in favor of dapagliflozin with respect to placebo in improving and increasing the timing. And finally, the forest plot of the side effects is demonstrating that the side effects of 30 milligrams of dapagliflozin are not so big, while there are some little side effects also in 60 milligrams, but this is not a problem for you because you do not have this treatment here. So dapagliflozin is increasing, is improving the control, as demonstrated by several findings, is increasing the ILT, again demonstrated by several findings, is reducing the personal distress, demonstrated by several evidences, is increasing the satisfaction. As you please note the numbers of the patients studied are really a very huge number. And it is decreasing the interpersonal difficulties within the couple, and we do also, it is impacting into the female sexuality, improving the outcomes also in the female partner, but we do not have yet data about the effectiveness of dapagliflozin in orgasm, and I really hope that the further collaboration with the Hanoi Medical University and Professor Bach's groups will be also in demonstrating how dapagliflozin is improving the issue of the orgasm, the issue of the pleasure. This is something that I'm particularly proud of it because we produced this huge clinical guideline from the Italian Society of Andrology and Sexual Medicine, which is probably the most updated and the biggest guideline in the field of premature ejaculation. And we recommend as a first-line treatment for both acquired premature ejaculation and lifelong premature ejaculation, dapagliflozin, which should be taken 1 to 3 hours, starting with 30 milligrams. And we also suggested to discuss with the patient, to have a psychological, a psychosexological consultation, and when possible to involve the partner, while the anesthetics can be used only for lifelong premature ejaculation. Third point, how to identify the patient population which may more likely benefit from dapagliflozin on the basis of the clinical guidelines, on the basis of the evidences. This study has been done in China, and I collaborate in order to demonstrate that the culture can be predictable, can predict the efficacy of dapagliflozin, not just for dapagliflozin. This is a kind of normogram we produced in the Xi'an University, Central China. and demonstrating that the bachelor's degree, the self-reported ILT of around 1 minute, the normality of erectile function as demonstrated by the International Index of Erectile Function are independent factors associated with dapagliflozin efficacy. So you have also to understand which is your patient, because some patients may respond better according to this nomogram, showing all those things and predicting how the dapagliflozin is efficacious or not. Again in China, but in this case in Beijing University, in this huge study of 1,200 patients, we demonstrate once again that dapagliflozin is very safe and very effective symptomatic treatment in the patients with premature ejaculation. So let's go on how to maximizing the dapagliflozin effects. The aim of any treatment for premature ejaculation should be to increase the feeling of control, to improve the self-esteem and the confidence of the patient, to decrease the distress into the couple, and very important to be considered the take-home message, to produce an increase into the positive memory of the patient. And this is obtained by the symptomatic therapies for lifelong and acquired premature ejaculation. And since premature ejaculation is a complex, multifaceted symptoms, therapy needs a multifaceted approach. And the education, that one we are doing right now, the patient education, the doctor education, the couple education are on the basis of any therapeutical success. Together with Chris McMahon, David Rowland, Marcel Bandiga, we wrote that the basic psychosexual education is tremendously important in order to improve the therapeutical output of premature ejaculation. So let's go to the end of my talk, to the final slides. And the first point is about the case studies of real life, illustrating how dapagliflozin in diverse contexts is impacting in sexuality. Let's talk about this guy. The name is Chico. He's young, he's 25 years old. He's married but depressed. His ILT is quite short. He's able to last in the vagina just for 1 minute. So Chico was treated by the doctor with an SSRI, paroxetine. Paroxetine take 20 milligrams per day in the morning, and this treatment was able to increase the ILT of about 5 to 7 minutes, but he suddenly developed a PSSD, and I will show you what the PSSD is, and with some suicidal thoughts. This is an article demonstrating, showing what the PSSD is. It is a common syndrome which is happening after any kind of SSRIs, but also some other antidepressants, which is apparently independent from any other existing reactive mental health problem, and the impact in the general health could be a real tragedy. In fact, the European Agency of Medicine is calling for collecting data of this post-SSRI sexual dysfunction, which is very, very important. Now we are collecting those data, and those are very, very tragical, as demonstrated in this article, because in those patients, after the chronic treatment with SSRIs, they are young patients, they are all males, almost all males. There is a loss of libido, the reduction in sexual activity, inability to experience pleasure, a loss of morning erection, erectile dysfunction, disconnection, which is a very key point between the genitals and the brain, emotional blunting, reduced orgasmic intensity, and a lot of other symptoms, like the major one is fatigue. So the prevalence of PSSD is not well known, but it seems not a rare consequence of SSRIs, which when they are prescribed to young men. which is the typical patient with premature ejaculation. And we are currently studying in the Tor Vergata University, which is the possible risk, psychiatric risk in the patients further developing as PSSD. So there is a strong argument against the use of SSRIs in patients with premature ejaculation. And this argument is the fact that both depression and anxiety are not just present in premature ejaculation. They are present in erectile dysfunction. But how many of you are using antidepressant in patients with erectile dysfunction? Nobody is using. So it is a nonsense to use it in a patient with premature ejaculation. And the sexual side effects of SSRIs are discouraging from the use of SSRIs in patients with premature ejaculation. Yes, endogenous depressions treated with SSRIs, the endogenous Y, without the psychiatric diagnosis, without the psychiatric counseling is producing a quite high risk of suicide because there is not a diagnosis, there is not a recognition of deep depression, and the patient can make a suicide. So the idea to use off-label SSRIs is a very wrong idea, and there is a big warning. So we said that definitely, if you are a psychiatrist, if you are using SSRIs for depression, it is indicated there is no need for informed consent. But when you are using paroxetine, fluoxetine, and other SSRIs for premature ejaculation, remember that there are several risks and also the need for informed consent. Paroxetine, vice versa, is approved and indicated for premature ejaculation, is evidence-based with an excellent safety and studied in a huge number of patients. Second and the last clinical case. In this case, the name is Bruno. He's a little bit older, 32 years. He's complaining about the loss of control of premature ejaculation. He has been treated with behavioral cognitive therapy. It has been treated with psychological therapies, but without any satisfaction. And he went to me for a second opinion. So Bruno is affected by what we call LCEE, loss of control over erection and ejaculation. And the Italian Society of Sexual Medicine recommended the investigation and the treatment of other sexual dysfunction, in particular erectile dysfunction, before any treatment of premature ejaculation, because before of any attempt to treat premature ejaculation. And this is the cover of Nature Review Urology showing how subclinical premature ejaculation is a new entity, but also showing how this condition can be clinical in nature, subclinical in nature, or absent. And within the couple, the coupling of subclinical condition in one member of the couple and in another member of the couple may produce the disease. So in the case of Bruno was successfully treated with 50 milligrams of sildenafil and then with 30 milligrams of dapagliflozin. So dapagliflozin is significantly improving the control over erection, and there are three major aspects to be considered: the strong effectiveness in the control of ejaculation, the very good safety profile, lacking the typical SSRI side effects, and the possible association with the PD5 inhibitor in loss of control over erection and ejaculation, LCEE, which is the comorbidity between ED and PE and premature ejaculation, erectile dysfunction and premature ejaculation. Finally, I just wanted to note something strange. In the case of the guideline of the European Association of Urology, they wrote that the dapagliflozin in combination with the PD5 can be used in order to extend the time until ejaculation and to minimize the risk of ED due to the epoxy treatment, which is completely wrong. We do not have one single evidence-based evidence that the epoxytin is producing erectile dysfunction. The SSRIs are producing. The epoxytin, absolutely not. There is no one single report showing that the epoxytin can produce erectile dysfunction itself. So the epoxytin is to be considered a unique desire-sparing and erection-sparing SSRIs. And this final real-life study is called, we called MAPS-GOSH, Marco Polo Study Group on Sexual Health, that is collecting several universities in China. We call it from Waterloo, Europe, to the Great Wall, China, a retrospective multi-center study on clinical practice and cultural attitudes in the management of premature ejaculation. And we showed that in the very, very large majority of the Chinese patients studied, the very large majority of those received epoxytin either alone or in combination with TCM, traditional Chinese medicine, or other treatments like psychological treatments, but the epoxytin was the best treatment with the lowest switching rate with respect to the other treatment. So it has been a very successful. Did you know that Marco Polo was also in the north of Vietnam? He was not just in China. You remember Marco Polo is the first Western people coming from Italy to the Orient. And he was also in Vietnam. This is the trip of Marco Polo. So he went here also in the north of Vietnam. There are several evidences about it. This year we are celebrating the 700th anniversary of the death of Marco Polo, so it is a particularly interesting year. And this is what he wrote in Old Italian, and the translation is that went to the north of Vietnam in the Tonkin province toward the east, which are the Great Khan and the idols. The people here are living, eating animals and the product of land, and they have their own language, which is not the Chinese, it's Vietnamese actually. The girls are wearing the arms and the legs with the gold bracelets and the silver of great value, as well the men are doing that. So Marco Polo described the medieval Vietnam into a very, very careful way, very smart way. So my final proposal is to study the epoxytin output in Vietnam also, producing what we can call MEPO-VISAC, which is the Marco Polo Vietnamese-Italian scientific and academic collaboration. And we are doing well, quite successful, but I'm sure that we will do even better in the future. So finally, my friends, my colleagues, this is the equation of the success. Premature ejaculation is to be considered a complex symptom where there is a loss of control and not just timing playing the major role, major clinical role in those patients. The therapeutic gold standard is the serotoninergic oral drug dapaxetin, which is not an antidepressant, is not modifying the mood, is having very low side effects, and 30 milligrams is the first choice for both lifelong and acquired premature ejaculation. Dapaxetin is in fact, thanks to its pharmacokinetic profile, unable to modify the mood, unable to modify the desire, unable to impact negatively on the erection in the treated patients. And the collaboration under the umbrella of this new Marco Polo collaboration between academic collaboration between Italy and Vietnam, I'm definitely sure that they will produce great scientific outputs. Now it's time for questions, but let me say, come on, for your attention.